Okay. So good evening, everyone from India. And we are back again with one of the most powerful sessions again. Yeah. So I wholeheartedly welcome you all at Global Interdisciplinary Summit 2020. So I, on behalf of the team member, Dr. Gagandeep Kaur, is presenting with you Dr. Heidi with us. So we are having one session with her. We'll be starting within a moment. And for all the participants, I would like to guide you that you all have to fill a registration form in between of the session. The link will be shared in between. And following that, you have to take a screenshot of the seminar, which will be acting as the proof of your attendance. So follow that, you have to register, and for all the C certification and participation certificates, you can log into www.gomha.org. So with this, we'll move on to the event of the day, the session of the day. And speaking about Dr. Heidi, she's the owner and managing oral maxillofacial radiologist in dental radiology diagnosis and a Dents by Sirona 3D trainer. In addition, she is an adjunct professor in the Department of Diagnostic Sciences at the University of North Carolina at Chapel Hill. She received her DDS degree from Loma Linda University in 2003, and in 2012, she received her master's degree in oral and maxillofacial radiology from UNC Chapel Hill. Her master's research compared 2D versus 3D radiography in the treatment planning of root canal treated teeth with the apical radiolucencies. In 2017, Doctor received her PhD in diagnostic imaging and with an emphasis in the craniofacial radiology at King's College London, focusing on the validation and diagnostic efficacy of 3D surface models in dentistry, temporomandibular joints. So with this, I would welcome Dr. Heidi with us. Ma'am, you can go with the session. The stage is all yours.
Thank you so much. I appreciate that.
Thank you.
All right. Are you able to see my screen?
No, ma'am. Yeah. There's a share screen option at the bottom of the screen. You'll find that.
There we go.
Yes, ma'am.
Perfect. Thank you. All right. I'm going to go ahead and let's see if we can.
Ma'am, you want any help?
There we go. Can you see that okay?
Yes, ma'am. That's perfect.
Okay. Perfect. All right. So today we're going to be talking about cone beam CT, the role of 3D imaging in digital dentistry. And thank you so much for that lovely introduction. I really appreciate that. So yes, as you had stated, I'm adjunct assistant professor in diagnostic sciences at UNC Chapel Hill. I've been a professor in some capacity for the last 16 years. And I am a founder and managing oral maxillofacial radiologist for dental radiology diagnostics, as well as DRDX Doctors, which is our new educational website that we are currently working on. The learning objectives for this course, we want to have a better understanding of how cone beam CT works, what we should be considering if we are thinking about purchasing a unit, talk a little bit about radiation doses and risks associated with our cone beam CTs, as well as our legal ramifications of owning it, and what are the current clinical applications for cone beam CT. As you'd say, some of my disclosures here, I always want to make sure everybody's aware that I do have some conflicts. I am an opinion leader and lecturer for Dents by Sirona, Henry Schein, Patterson Dental, and a consultant for CEREC Doctors. So we're going to use the Socratic method today when we're talking about our cone beam CTs. We're going to ask various questions, and hopefully these are questions that you have asked and other questions that I have asked over the years. What is cone beam CT and how does it work? What should you consider when purchasing a CBCT system? What are my radiation doses and risks? and my legal responsibilities, and how can I use my cone beam CTs. So first of all, let's talk a little bit about what it is. And let's demonstrate what's the problem with imaging 3D objects in 2D. Well, here's a picture we have of Prince William, very shocking picture. It looks like he is making rude gestures toward the Associated Press. And we thought, wow, he's such a nice guy. What's going on? Well, this was splashed all over the newspapers. But what was really happening? If we look at him from the front, we can see he's really saying, I now have 3 children. So your perspective is very, very important. And we know that 2D does not always give us all of those perspectives. So where can we go from here? Well, we can go into the third and the fourth dimension being time. And so we'll talk about that. We're talking about cone beam CT. We really have 3 main advantages. First is in diagnosis and treatment planning. Next, it becomes the foundation for our digital dentistry. What you can do with this technology is really just the tip of the iceberg, and we'll talk about that. Patient education, this is a fantastic tool for patient education. You can actually show Mrs. Jones for the first time exactly what's going on in her mouth. She can see it with you as you're going through your scan. You can point out where you're going to be placing an implant or how that relates to the mandibular canal. Our cone beam CTs are really a combination of 3 different technologies. So it uses a C-arm fluoroscopy, the image intensifiers or flat panel detectors. So the very original cone beam CTs that came in were all made with image intensifiers, very similar to what we see with those cardiac imaging fluoroscopy units. We use the algorithm for medical CT, which is just an amazing algorithm. And we'll talk about that a little bit later as well. And of course, this fits onto a panoramic platform so that it fits into your dental office. All right. So as it's rotating around your patient, what it's doing is it's actually taking multiple basis projections or multiple images. It can take 600 plus images in about 14 seconds. And of course, we can see what it looks like on our screen as that image is actually being taken. Now, your computer will put this together using that algorithm for medical CT and form the images that you actually see on your screen. So this particular image, what we're going to see on the left-hand side, it's actually going to be an abdominal view. On the right-hand side, we're going to see the ray as it's rotating around our patient. So as that's rotating around, your computer is solving all these mathematical equations, that algorithm, and forming the image that you see actually on your screen. Now, why is this good to know? Well, it lets us know that we can continue to get meaningful upgrades over time through the software. So, if you're worried about the technology being obsolete like our iPhones, once you purchase this, you'll actually continue to get upgrades over time. So the machine that you have in 5 years from now will actually be better than the one that you have today. So how is this different than a conventional medical CT? Well, on the left-hand side, we see our conventional medical CT. And this has a very highly collimated fan beam. Because it's such a highly collimated fan beam, we actually have very little scatter. So it hits the receptor is actually 95% signal, only 5% scatter. And that's why we have excellent soft tissue detail when we're looking at a medical CT. Now, this has multiple revolutions and it has an unlimited scan volume. It can go from your head to your toes very quickly. This does come at a higher cost as well as a higher dose to that patient. On the right-hand side, we see our cone beam. This really is a very large cone beam. It's not the highly collimated fan beam that we see with medical CT. And because of that, we actually have lots of scatter. So it hits the receptor is going to be about 80% scatter and only 20% signal. And that's why it's really used for hard tissues only. We don't see the soft tissues that you see with medical CT. Now, sometimes people say, well, I really wish that I could see that soft tissue. Well, there's a lot of soft tissue when we're talking about the head and neck. There's all of the facial muscles. Of course, you'd probably pick up on some brain. It's a very good thing that what we're seeing in dentistry is really just the hard tissue, because that's really what's useful to us. It would be time prohibitive if we had to go through and evaluate all of those soft tissues, and it really wouldn't serve its purpose for dentistry. We say that this has one revolution. It goes around the head, so very limited scan volume. It's just for the head. But we do see people sticking their hands or their feet in it or whatever else it is that they think that they've broken. In fact, they'll send it to our private practice and say, "Hey, doc, did I break my ankle while I was skiing last weekend?" Of course, we do say it's for the head. So as a radiologist, I have to say, don't try this at home. As a dentist, I totally understand. I'm going to stick whatever in it it is that I think that I've broken. But my legal caveat for radiology is it's supposed to just be for your head. Now, this does come at a lower cost as well as a lower dose to the patient. All right, so what should you consider when you're purchasing a CBCT system? There are a ton of systems on the market. In fact, every single day there's a new system coming out. So it becomes very confusing for us. How do we know what to get? Well, we get a lot of questions. People ask us which system has the best imaging quality, or what is the best cone beam CT system? And I'll tell you, that's really not the question to be asking. Just so you know, all CBCT systems are diagnostic. So everyone on the market will work. So how do I know what is right for my practice? Well, let's think about some other things. First of all, what are you going to be using it for? What are the fields of view and resolutions needed for the tasks that you will be doing? So if you're an endodontist, you probably want a higher resolution and a smaller field of view. If you are an orthodontist, you probably want a larger field of view, and you probably don't need that high of a resolution in comparison to an endodontist. Is the software intuitive and easy to use? And this is a really big one. We'll see people purchase a machine, and if they can't figure out the software, they won't use it. So you want to make sure, if you're considering purchasing a unit, that you play with the software ahead of time, that it's something that you're going to be able to figure out and that it's easy to use for you. What type of support is offered by the manufacturer? And this one's very, very important. There's a lot of things that go into these particular units. What happens if something goes wrong? Is there somebody that's going to be there to help you? So you want to make sure that you ask about the manufacturer and make sure that it's a company that's going to stand behind you and be with you. So let's talk about some of those fields of view. Now we have a larger field of view. So these are just example representatives of various fields of view. So in this one, we can see that we have a larger field of view right here. We have a medium field of view, a medium large 11 by 10, and a medium smaller 8 by 8, and then a small 5 by 5. So we have quite a lot of variability in your fields of view. So this is a 15.5 centimeter square, or I'm sorry, sphere for this particular one. That's because it's an image intensifier screen. And this is what this particular unit looks like in the various software. So we can see that with this particular unit, we're able to see our temporomandibular joints. We can also see the airway. We'll be able to see the cervical spine, but you're also going to pick up on things like the cranial base. So you have a very large field of view. All right. This is an example of a medium field of view. Now this is a flat panel detector. A flat panel detector is going to make a cylinder instead of a sphere. So it's just a little bit of a shape difference. And in this particular size, this is what you'd be able to see your maxilla, your mandible, and your airway space. But you're really not going to pick up on your temporomandibular joints. So if you really want to see that, you'd want to get a larger machine. Then we have an 8 by 8 and of course a 5 by 5. An 8 by 8 is really going to be something that is a workhorse for implants. You have your maxilla and your mandible, but you're really not going to pick up on your airway, your temporomandibular joint. And of course, the smaller fields of view are what you would want for endodontic purposes. So let's look at what they look like in their software. So here we have an 8x8. And again, you're seeing your maxilla in your mandible, but you're really not going to get airway and temporomandibular joints. But you will be able to use this very, very nicely for implant purposes. And these are the higher resolution images. This is a smaller field of view, that 5x5. Very high resolution. You can see the periodontal ligament space very nicely, very great for endodontic purposes. Now, in reality, many machines are variable fields of view, and they will contain all of these and let you choose. And I really do like variable fields of view because I like to be able to make the decision as far as what size I want. All right, what are the radiation doses and risks associated with a cone beam CT? All right, let's talk about this. Excuse me. So a lot of patients are very, very concerned about radiation risks, as well as dentists. You want to make sure that we're decreasing that risk for our patients. We find that across the spectrum, we're talking about CBCT dose, it can be highly variable. It will depend on the individual machine, the volume, the detector type. So there's a little bit of differences between an image intensifier that intensifies the signal coming in versus a flat panel detector, but it's fairly minor. Image resolution. So the higher the image resolution, the more images your machine actually takes, which makes it a little bit more dose. Those number of basis projections, those number of images that are taken makes a difference. And on average, it's less than conventional medical CT. So when we're talking about cone beam CT and we're looking at doses and we're looking at various papers to try to compare machines, what we always want to look at is the effective dose. The effective dose takes into account the volume as well as the sensitivity of the tissues to ionizing radiation. And we want to make sure that we're always using the latest tissue weights when we're looking at our effective doses. And the latest tissue weights were taken from the 2007 ICRP tissue weights. So you always want to make sure you have the most up to date. So keeping that in mind, when we're looking at all of the large field of view units across the board, we can see that they're highly variable for all their various protocols. And so the dose can vary between 46 to up over 1,000 microsieverts. But on average for a large field of view, it's about 212 microsieverts. So that's the average. So if you're looking at a particular machine and you're comparing things, if you want a large field of view, just know that 212 microsieverts is about the average. And then you'll be able to tell whether the machine you're looking at is more or less dose than that. Medium field of view can vary between 9 to 560 microsieverts. On average, it's 177 microsieverts. Small fields of view can vary between 5 to 652. So you can see that just because it's a larger field of view, it doesn't necessarily mean that it's less dose than a medium field of view. So you can see that the dosages are highly variable and there's always outliers. So just because you have a small field of view, again, doesn't mean it's less dose than a larger unit. But on average, a small field of view is 84 microsieverts. So we can say on average, the smaller the field of view, the less dose the patient will receive. All right, so how do I compare this with other things that we do in dentistry? So we just picked on average an 8x8 centimeter field of view. This is an average adult setting for this particular unit. And we can see that it equates to about 6 to 7 panoramic radiographs. These are our digital radiographs. About a third of a film-based full mouth series. So those old film-based full mouth series were actually quite a lot of dose. You could take 3 scans for the amount of dose that a film-based full mouth series is. It's just slightly more than a direct digital full mouth series. It equates to about 15 days of background radiation. So background radiation is the amount of radiation that you get just being alive every day. So for example, in the United States, we get about 8.5 microsieverts just walking around being alive. So we can equate the dose from our cone beam CTs to that background radiation, and I can say it's about 15 days of being alive on the earth in the United States. Now, what's the chance of a birth defect from in utero exposure? Everyone's very concerned about this, and the chance is actually 0. So let me talk about that a little bit, because I didn't learn that when I went to dental school. When we're talking about our ionizing radiation, there's actually 2 different effects that we see. We see a stochastic effect. This is based on statistics. We see a deterministic effect. And let's talk about those a little bit more. With the stochastic effect, it's where the risk is proportional to the dose. And it implies there's no threshold. So the currently held medical models, or mathematical models, I should say, imply that there is no threshold, that the damage from ionizing radiation could slowly accumulate throughout the lifetime of that patient. At some point, the body may not be able to clean up that damage, and a cancer could begin. So we see this with cancer and genetic effects. Now, the severity of the effect is independent of the dose. So if Mrs. Jones is diagnosed with stage 4 cancer, it does not mean she had more dose. It just means at some point something triggered a cancer to begin. Then we have our deterministic effects. This one, the severity is proportional to that dose. And we have a defined threshold, or implies we have a defined threshold. So I can say at a certain amount of radiation, I will see a particular effect, but under that amount of radiation, we will not see that effect. And we see this with things like in utero birth defects, cataracts. There's actually a radiation cataracts that looks different than senility cataracts. We can see with radiation burns. Now we have sunburn there, not because we want to equate an X-ray with being out in the sun, but a sunburn can be a deterministic effect. It's a time-dependent deterministic effect. So if I stand outside for 15 minutes, I'm probably not going to get a sunburn. However, if I'm outside for 4 hours, I know I'm going to get a sunburn. So it's, again, a time-dependent deterministic effect. Now, the dose threshold for in utero birth defects is between 100 to 250 millisieverts. Now, remember, in dentistry, we were down in the microsievert range. So let's talk about that just a little bit more. This is the reference from the Health Physics Society. It feels that most diagnostic procedures expose the embryo to less than 50 millisieverts. Now, this level of radiation exposure will not increase reproductive risks. And according to published information, the reported dose of radiation that results in an increased incidence of our birth defects or miscarriage is actually above 200 millisieverts. And again, remember in dentistry, we're talking about microsieverts. So we're really orders of magnitude below that threshold. So there's 0 chance of in utero birth defects with anything that we're doing in dentistry. Now, taking that into effect, we always want to decrease the dose for our patients. We know that damage from ionizing radiation may slowly accumulate throughout the lifetime of the patient, and it may start a cancer. So you always want to be careful with dose, and particularly with the pediatric population. There is actually something called the Image Gently campaign. It's actually mandatory for physicians to sign the pledge that they're going to be very careful with dose for the pediatric population. And it's a particularly sensitive population. We know that children are much more sensitive to ionizing radiation. So we want to be very protective of the pediatric population. So if you haven't, I know this is coming into dentistry, if you haven't gone to the Image Gently campaign website and taken that pledge, please do. I'd really encourage you to. In fact, you can actually, once you've taken the pledge, take their logo and put that on your website. And it lets your patients know that you're going to be very cognizant of dose. And you're very, very careful, particularly with the pediatric population or the highly sensitive population. But with that, a lot of companies are now offering ultra low dose protocols, which I think is just fantastic because this will decrease the dose for those patients. And so when I'm talking about the ultra low dose protocols, I want to give you a couple of benchmarks just really quickly. If I am comparing it with a panoramic, that's about 14.2 microsieverts. If I'm comparing it with 4 bite wings, that's about 5 microsieverts. So that will give us some benchmarks to go off of when we're looking at how much dose this is. So in this particular machine, they use an ultra low dose protocol. They wanted to see where the mandibular canal is in connection with the tooth roots, which we can very nicely see in this particular image. And this was taken at an effective dose of 19 microsieverts. So 19 microsieverts, it's just a little bit more than our panoramic image. And we have all of our 3D capabilities. So very, very useful for this particular task. This is an ultra low dose protocol that was taken for implantology. They wanted to look at where the implant was in relationship to the mandibular canal. And again, we can very, very easily see that in our blue circle right there. We can see where our canal resides in relationship to that canal. This was taken at 9 microsieverts. So for the particular task at hand, it really works. This is actually less dose than a panoramic image, and you have all of your 3D capabilities. This is another image, low dose protocol taken for orthodontic purposes. So we have a pediatric patient. We know we want to decrease the dose for our pediatric patients. And this was taken at 8 microsieverts. Now they wanted to know where the teeth were in relationship to each other, looking at path of alignment and that sort of thing. And we can definitely see that here. So for this particular task, it really works. And we have all those 3D capabilities. Now this is another one taken for orthodontic purposes. Now it does look a little bit noisy, but we can see the tooth. We can see the periodontal ligament space. And again, it could be used for looking at the relationship of that tooth to the surrounding teeth. And this was taken at 3 microsieverts. So this is actually less than a set of 4 bite wings. And you have all your 3D capabilities. So it's just amazing what the various companies are able to do with our cone beam CTs nowadays. We could use ultra low dose protocols for our patients. All right, what's the legal responsibility that comes with owning a cone beam CT? Who is responsible for reading this data? And a lot of times we really do get hung up on this. Well, it's the person that obtains the volume. It's the exact same thing as if you took a panoramic image or a lateral ceph. In fact, you're seeing all the exact same anatomy. It's just you're able to see it a whole lot better in 3D than we ever were with all of the 2D superimpositions. So we were always responsible for all of this data. It's just now we can see it better with 3D. Now, what is our ethical and legal responsibility? Well, the entire volume should be looked at. That's what our ethical and legal responsibility is. And if you notice that there's anything that is abnormal, then we would want to refer that appropriately. If you're going through your scan and you're not sure what it is, you can always refer that to an oral maxillofacial radiologist who is more than happy to help you with that. There's free training that's offered by certain manufacturers, and I would highly recommend taking that free training. Again, it's included in the price of your machine. You may as well enjoy it. And with any new technology, we always want to take additional training for that. And cone beam CT is no different. And again, there's oral maxillofacial radiologists like myself that are more than willing to help you with your cone beam CT if you're unsure of what you're looking at. We're very approachable. We're very nice people. There's not that many of us, so we usually know each other. And it's just a great group of individuals that are a wonderful resource for you to be able to use. And again, many of those companies will offer some type of free training. You can take training on CBCT anatomy and pathology and that sort of thing. All right. So when we're looking at our cone beam CTs, what we want to remember is that our radiographic signs really don't change. So these are all the same radiographic signs we had for 2D. It's the same thing for 3D. And when you're looking at our radiographic signs, you'll notice that there's 2 here that are underlined. And that's because they're the most important as far as letting us know how aggressive a particular entity is. All right. So what are the current clinical applications of cone beam CT? What can I use my cone beam CT for? Well, there's actually many applications. Of course, the first being implant imaging and treatment planning. This was the driving force. So we'll talk about that a little bit more as well. But we can also see developmental abnormalities, third molar canal relationships, periapical and periodontal findings. This is a really big one. This is actually what brought me into 3D imaging. And this is really what got me excited about cone beam CT. Temporomandibular joint imaging. This is fantastic for it. So I did my master's research in the endodontic arena. I did my PhD all looking at temporomandibular joint imaging. This is a great tool for that, looking at the osseous changes. It's fantastic for trauma. We don't have all the superimposition that we had with our 2D images, so it's very easy to see our fracture lines. Pathological findings, yes, we do see these. This is what it can be used for. We know that many of our professors used to tell us, you may not see pathology in your practice, but pathology will see you. So we want to be able to diagnose that when it's there. And it's much easier to see it in 3D than it ever was in 2D. Airway and sleep apnea applications, absolutely. We can segment out the airway space, but we're not diagnosing obstructive sleep apnea off of a cone beam CT. We'll talk about that a little bit later on as well. Great for orthodontic applications, as well as 3D segmentations, 3D printing, that sort of thing. So there's just a huge host of what you can use your machine for. So when do we move from 2D to 3D? Well, it's any time your 2D does not give you enough information. So if you don't have enough information to manage that patient, then you really should move into a 3D image. A couple of things that we do see. There's a general principle that we see time and time again, is that 2D consistently underestimates the bone loss and it overestimates the bone gain. Let's talk about it for implant site assessment. Really, this is what this technology was designed for. We wanted something that was low dose and low cost for the patient, and cone beam CT allowed us to do that. So the first papers that came out were in 1998 by Mozo, and that particular paper was discussing an Italian unit. That's the new tome. So that was the very first CBCT unit. In fact, the first one into the United States was in 2001, and it came into Loma Linda University in California, where I was a student at the time. So here's some examples of looking at why we might want 3D when we're talking about placing implants. So looking at this 2D image, our implant looks pretty good. It looks like it's osseo-integrated. We know the majority of implants will osseo-integrate. But when we're looking at the 3D, where is it actually located? Well, we can see the apex of the implant is actually sitting in air, and there's no buccal bone attached to this. So the implant's really only hanging on by just a little bit of palatal bone. So that's going to decrease the longevity of that particular implant. This is another one. This implant looks, based on our 2D image here, the implant looks like it was placed correctly. It looks restorable. It's something that we would probably be proud that we placed. But where is it really? When we're looking at the 3D, we can really see that that's positioned on the lingual aspect of the mandible. In fact, in looking at the cross sections, we can see there's very minimal bone actually hanging onto that implant, the implant's really not restorable as it is. So we know that that 2D image we saw previously was kind of lying to us. It wasn't telling us the truth. Now, this is another image. This particular clinician, who, might I add, is a wonderful, wonderful clinician. He's actually a specialist, and he's placed thousands of implants throughout his lifetime. So as radiologists, we do see the good, the bad, and the ugly. And we have a very wide no judgment zone because we know that things happen. Everybody has a bad day. And this just happened to be his bad day. Now you can see that he's measured the amount of bone that he has based on an angled posterior maxillary PA. But that's not really the amount of bone. In fact, came running down to radiology with the patient, and the comment was, we lost the implant. Well, we were definitely able to find the implant with the carrier mount that is attached. So very, very bad day again for the clinician and the patient. And if they'd had appropriate imaging, this may not have had to happen. Now, this is a position statement that was set out by the American Academy of Oral Maxillofacial Radiology in conjunction with dental implantology. And it recommends the cross-sectional imaging be used for the assessment of all dental implant sites, and that cone-beam CT is the imaging method of choice for gaining this information. Excuse me. All right. And another great reason for cone-beam CTs is using a surgical guide. This is a fantastic reason for a cone-beam CT. A surgical guide really makes it easy for you to be able to place those implants. And it comes with a nice recipe. It comes with an accuracy for how those results for that positioning of the implant should be. And it's just a very, very nice thing to use, especially if you're first beginning to place implants. It's nice to have a really easy recipe to follow and a nice guide so you know you're placing that implant where you want it to go. Because we know that just because you have a large area to be able to plan that implant, we don't always place it freehand where we want that to go, and that can cause a lot of problems. So having a surgical guide to be able to help to guide exactly where we want that implant to go is extremely beneficial. And it decreases the amount of time it takes to place that implant as well. So you get your money back on that. Developmental abnormalities, absolutely. This was a case in which they were expecting this canine to erupt, and it hadn't. They were concerned about their treatment options. Perhaps they could uncover it and chain it, bring it down. But when they took the cone-beam CT, they found that there's really no periodontal ligament space along that palatal aspect. And in fact, it's ankylosed to the palatal bone. So that'll change the course of treatment for this particular case. Here's another one. We have kind of an unusual dental anomaly, and this is a young individual. So decided to go ahead and take the cone-beam CT to see what's going on. And there's actually a supernumerary tooth that has fused to the buccal aspect of that second molar. And so definitely that would be an issue if we had to restore that tooth or if we needed to have endodontic treatment on that tooth. This is another one. So if we're looking at this, this is actually an 8-year-old female. And yes, the tooth number 9 is hypoplastic, but tooth number 10 has been causing a lot of issues. In fact, it's already had root canal treatment, but is continuing to have drainage. When they took the cone-beam CT, we can see there's a secondary root that was found on a lateral tooth. Definitely not something that we would have been able to see just based off those 2D images. It's another interesting case. This was sent in by an endodontist, and they were very concerned about what tooth should be root canal treated to try to heal this particular lesion that they were seeing. So should we go ahead and root canal treat tooth number 7 or retreat number 8? When we're looking at it in our cone-beam CT, we can see, no, we have an undiagnosed cleft palate. Now, this was actually a 60-plus-year-old female. We can see that this bony defect is what was being projected onto our 2D images. That's why it made it look like there was a lesion when in fact there really wasn't. We went ahead, we wrote the report, we sent it back to the endodontist, and they actually called us back and said, well, the patient says she doesn't have it. Doesn't have what? Well, she claims she doesn't have a cleft palate. So I always find this to be funny. I've never seen a patient that actually wanted to have root canal treatment, but evidently she did. And it's what the beautiful part with radiology is. It's really just the facts. So I could say it's just the facts, ma'am. There is an undiagnosed cleft palate. It's another kid. Looks like we've got something going on around those unerupted third molars. Maybe we have supernumerary teeth. Maybe we have a compound odontoma. Went ahead and took the cone beam CT, and you can see that it's actually additional little supernumerary teeth in their own little follicular sacs. So it's not a compound odontoma. We see one additional third molar. We call them a fourth molar or a paramolar on this side. And we have two little cuties on this side. So they, again, they're in their own follicular spaces. In this particular case, off of the cone beam CT, they could see what looked to be a lesion. In fact, it looks like it's a cyst or a tumor. In fact, they were going to do a biopsy on this based on this image. But luckily, a 3D image was taken first, because what we actually have is an anterior Staphny bone defect. Now, we do have some large lingual tori as well, but you really can see that there's something that is peripheral that's pushing in on that bone. And that, again, our anterior Staphny bone defect, it does not need to have a biopsy. Third molar and canal relationships, definitely we can see those. This happens to be an area of interest right now. We're starting to see a lot of cases with this, legal cases, where they're saying, well, we should have had a cone beam CT. Maybe we'd be able to see things a little bit better. Well, in most patients, we are able to see the relationship of the mandibular canal to those tooth roots. In fact, a case like this, you might look at and you decide you'd like to refer that to an oral surgeon. We can definitely see we have impingement of the canal. That's the yellow arrow there. You can also see how close those tooth roots are to the inferior cortical border of the mandible. So you can be concerned about having some type of a mandibular fracture with extraction. Unfortunately, in this case, there is an oral communication, and this patient does have a periapical lesion with this. So the tooth did need to come out. This was successfully removed in the OR, and the patient was very aware they could end up with neurosensory deficits or a jaw fracture, but that case ended up very well. Endodontic and periodontal applications, absolutely. In fact, again, this is what really brought me into 3D imaging. So there's nothing worse than having a patient come in, you've placed the endodontic treatment, or you've performed the endodontic treatment, placed a post and crown, and they come back with continued pain. And of course, as dentists, we want to be able to fix that for them. So if we're looking at this particular case, based off the 2D image, yes, we do have a periapical lesion. It looks like it's centered at the apex of the tooth. It doesn't look like it extends up to the large post. But when we look at it with our cone beam CT, we're now looking between cortical borders. So we're definitely able to see what's actually going on with that particular tooth. And we do see that we have a J-shaped radiolucency. It extends right to the termination of that post. Lets us know we have a root fracture. Now, because of imaging artifacts, we may not always see the fracture line with a cone beam CT. However, we do expect to see the evidence of a root fracture to be able to call it. And so those are the types of things that we're looking for. If we have a non-healing root canal treated tooth, you want to look for either an additional canal, or if you have that evidence, that bone loss that tells you that you do have a root fracture. Now, it's very important to pick up these lesions early on, because research does reinforce the need for early detection. There is an association between apical periodontitis and cardiovascular disease. Not really a surprise. Anytime we have any type of a chronic inflammatory process going on, we're going to have an increased risk for cardiovascular disease, whether we're talking about periodontal disease or an apical periodontitis. Now, the size of that apical lesion at the time of root canal treatment does determine its success. So if you have a very large lesion, when you treat that tooth, there's less chance it's going to be a successful treatment. And so you might want to think about other things. Perhaps it would be better in a particular case to extract the tooth and eventually place an implant for Mrs. Jones, rather just than to root canal treat it. This technology can definitely be used when we're trying to figure out which tooth is bothering our patient. So this patient came in, she's actually been in several times. We're not sure which particular tooth it is. But when you take the cone beam CT, it clearly shows which tooth has a periapical lesion. In fact, in this particular case, you can actually see that there's a mucosal thickening in the sinus, and that is odontogenic in origin. In fact, you've lost the inferior cortical border of the maxillary sinus on that side. And so we know that, yes, we do have a nice lesion with an associated mucositis that is odontogenic in origin. And sometimes that's the first thing that you pick up. So if you're looking through a volume and you see a localized mucosal thickening in the sinus, we always want to check the teeth and rule out an odontogenic source for that. We can also see it with periapical lesions as well. So this particular case, with if we have any type of a periodontal lesion. This patient came in, there was drainage, there was pain. We had got a percha point. We were looking for where that drainage is coming from. The 2D imaging looks great. The periodontal bone looks like it is an appropriate level, maybe just slightly limited or slightly mild periodontal bone loss with that. But when we're looking at it with our cone beam CT, you can see a huge buccal bony defect. So we do have a lot of periodontal bone loss with this case, but yet it didn't show up in those 2D images. And why was that? Well, when we have inflammation, we can get thickening and sclerosis of cortical borders. That's very common. And with this patient, we had a very thick lingual cortical border, and that's what was being projected across and shown up in those 2D images. So you can see the degree of buccal bone loss, and yet our 2D images weren't able to pick that up. It's fantastic for our temporomandibular joints. Again, this is what a lot of my PhD was working on, was the temporomandibular joints. With this, we use the research diagnostic criteria for TMD. We use the osseous research diagnostic criteria. And that's a great criteria to use. It's put together by a cohort across the United States as well as Europe, basically trying to standardize the diagnosis for temporomandibular joint disorders. And they've taken 11 different criteria, funneled it down into no osteoarthritic changes or indeterminate for osteoarthritic changes, which would be flattening. We see the arms are adaptive remodeling, which is what we see with flattening. So many times with flattening, what you can see is, yes, that condylar head looks like it's flat, but you have smooth, intact cortical borders. They're thin, but they're intact cortical borders. So this could just be adaptive remodeling. And then we do have osteoarthritic changes, and we can see those. So we might have bony erosions within those cortical borders. We might have a little anterior osteophyte. It gives us that bird beak appearance. Or we can see that generalized sclerosis. So again, anytime that you have an inflammatory process, you're going to have bony sclerosis. The body is laying down bone to try to wall that off. We can also see subchondral pseudocysts. It looks like we have a nice little cyst within that condylar head, but it's a pseudocyst. It's not epithelial lined. They can occur again as a breakdown of that bone in response to inflammation. And so these are the types of things that let us know, yes, we have osseous osteoarthritic changes. It's great for trauma applications as well. Again, we don't have all the superimpositions that we had before, so you can really see the fracture lines very easily. This particular case, the patient came in and she is in pain. She's had a recent extraction. And with this, we can also see in our cone beam CT that additional bone is being laid down. We have a periosteal reaction with this particular case. So it lets us know that we have an osteomyelitis going on. In this case, there was actually a mandibular fracture with an osteomyelitis. Pathological findings, again, we do see those. What we want to remember is that we can always use symmetry. So if you're first starting out looking at these, I can compare one side to another. In this image, you can clearly see there's a difference between one side versus the other. So even if you don't remember that this is fibrous dysplasia from your dental school days, you would look at this image and say, you know what, something looks wrong. I would like to send this on to a radiologist to get a better view. So you can always refer your patients. This is another one sent to us. Why does the bone look so funny? Well, this patient has florid osseous dysplasia. We usually don't recommend implant placement in these patients just because we have this fibrous turnover of the bone. There's some disagreement as far as the literature shows whether you can place implants in these patients or not. We tend to recommend not, just because we're not sure how or if it's actually going to osteointegrate. Sinus disease. We see a lot of things in the sinuses. The majority of patients will have something. About 80% of patients will have something within those sinuses. The majority we don't need to do a whole lot about, but we definitely will see that. So here's an example. We have a nice little polypoid mucosal thickening within the sinus. Should we worry about that? Well, we want to look at the cortical borders. Are they nice and intact? And yes, they are. This lets us know that we have some type of an inflammation that has gone on, very mild inflammation. Really, no further treatment is needed in an asymptomatic patient. In this particular case, they took the panoramic, and you could see that there's a hyperdensity, or we have a radiopacity there. They thought they were going to go ahead and do a biopsy to see what that was. And yet, when we look at it with our cone beam CT, you can really see that it's just a dense bone island and no biopsy is in fact needed. It's just dense cortical bone. We can see calcified carotid atheromas. They're usually around the C3, C4 level. They're lateral and posterior to the airway space. And we can see a nice arcuate hyperdensity when we're looking in the axial sections. It looks a little bit more like train tracks in our coronal sections. In fact, sometimes there's so much calcification that they'll actually show up when we're talking about, or when we're showing our volume renderings or our 3D skull views. Now, we know this does predispose the patient to an increased risk of stroke. So we might want to go ahead and send that patient on, particularly if they don't know that this is going on in their body, their doctor's not aware of it, and they're a hypertensive patient. We also know that there's also a link with our calcified carotid atheromas and myocardial infarctions as well. So this particular research came out and let us know that if you're seeing calcified carotid atheromas on a panoramic image, particularly if it's bilateral, that could be associated with an increased risk of myocardial infarction. So it's not just stroke. So it's very important to be able to send these cases on for appropriate treatment. Airway. Yes, we do see that we can segment out the airway space. This is particular software, can be used with any machine on the market. But what we're really doing is giving Mrs. Jones a visualization, saying you have a limited airway space. It doesn't take the place of a sleep study. So these patients will still need to go on and get an appropriate sleep study to be diagnosed. But this can open up a conversation and let Mrs. Jones know, hey, you have a really limited airway space. Let's talk about if you have other types of symptoms that could be related to obstructive sleep apnea. I do like to take into account the temporomandibular joints. I like the appliances that can be adjusted because we want to make sure that we're careful with where that patient is positioned. The research does show a significant association between obstructive sleep apnea symptoms and the temporomandibular joint disorders. In these particular cases, it was discovered that the position that the patient was put in with their appliance for obstructive sleep apnea had an effect on the condyles. So we want to be able to monitor our patients and make sure that we're not causing any types of issues down the road. We want to make sure that they're in a condylar conformative position. It's great for orthodontic applications with most of the machines, especially larger field of view. You can recreate a lateral and a PA ceph. We can use the 3D to look at the location and orientation of the teeth, morphology's relationship to other surrounding anatomy, and try to help us with the path of alignment. So in this particular case, it was taken for orthodontic purposes. We can see where the canine might need to be corrected. And according to our images, it looked like they could easily correct that particular canine. But when we looked at the actual volume in the cone-beam CT, you can see where that particular tooth is located and how little bone is actually holding it in place. So it's really been moved outside the ridge, or it's sitting outside of the ridge. And that's going to change the treatment plan for this particular case. Again, segmentations, we can color in various areas. We can say, I'd like the blue label and the mandible will come out. I want the red label, the maxilla will come out. We can look at things over time. We can overlay things. So for example, if we're looking at this, if we're looking at the skull, the red is actually coming towards us. The blue is going away. So if you overlay time 1 and time 2, we can really see what's going on with patients, whether they are orthodontic study patients or whether we're talking about our temporomandibular joints. So with these condyles, we overlaid time 1 and time 2. We can see the erosion or the bony defect. When we use color mapping, it really highlights where any of those changes are over time. So we can look at the disease progress over time, how fast it's going, how our treatments are working, that sort of thing. It can be used for periodontal defects as well. So this was a case in which there was a pre-defect and post-defect, and they looked at with 2D versus 3D. And in the 3D, they went ahead and segmented out the teeth, time 1 and time 2, overlaid it. We can use color mapping to show us where those differences are, and they'll highlight in red. Now, of course, this was an example study, and this one has a fairly wide margin to that ruler, but we can make it as specific as we want to make it. So that there's excellent applications for this in our dental offices. Now, anything you can segment, you can 3D print. So this was actually a scaffold of a condylar head that was printed out. They infused it with stem cells and regrew a new condyle for that particular patient. So how wonderful is it if we can replace that patient's anatomy with something that is anatomically correct for them? So the places that we're able to go, especially with 3D printing, is pretty impressive. This is a tooth that was 3D printed. They 3D printed it with an antimicrobial plastic. So it'll kill the bacteria in the mouth. You're probably not going to put that back in the patient's mouth, but it was really a neat study. But this was a case in which they did. So they went ahead, segmented a tooth, 3D printed it, and they used that 3D printed tooth as a placeholder. So there's amazing things coming down the line as far as what we can do. In fact, we know our digital dentistry is really just the tip of the iceberg of what we're going to be able to do in the future. When we're talking about cone-beam CT, we do want to be careful though. It's not a great modality for diagnosing caries. There are a lot of beam hardening artifacts. It makes it look like there's caries when they're not there. So we always want to give the caveat that we still need to use those intraoral images to diagnose caries. But it's great for everything else, from our endodontic applications to periodontal applications. We are not quite all-to-one imaging yet, because again, we need those intraoral bite wings to be able to diagnose with caries. So when we're talking about CBCT, it's just a great tool that we can have in our toolbox. We can do many different things. But again, I would stress you want to get the proper education when you purchase this, so you know how to appropriately use it and diagnose with it. And again, remember that the company is crucial. So you want to make sure that it is a company that is standing behind you and is going to be there for you. And so again, your support team is very important. So who's the winner in all of this? And all of this is always the patient, because they're going to benefit the most. And I like this statement by Dame Jane Goodall: what you do makes a difference, and you have to decide what kind of difference you want to make. So what kind of differences are you going to be able to make in your office with this type of technology? So thank you very much. I really appreciate it. This is when a radiologist takes a selfie. I always love this one. That's me in the center there. Nice straight nasal septum. Very excited by that. Thank you very much. I really appreciate you being with me today, and hopefully I've answered your questions.
Thank you so much, ma'am, for the beautiful lecture you took. And we're quite amazed with the knowledge you shared with us. So we're having some questions to be answered.
Okay.
Okay, I'll take the smaller ones because we are, I think, less with the time. Okay, so from Dr. Suraj, we have, can with cone beam, we rule out between abrasion and abfraction?
Can it tell the difference between abrasion and abfraction? It actually can't. What you're going to see is you're just going to see a loss of tooth structure. So you can see that something is there, but you can't tell the difference between abrasion versus abfraction.
Okay, and then we have the second part of question. According to PDL and bone changes,
I'm sorry, can you repeat that?
Yeah, I'll complete with the question.
Oh.
Can with cone beam we rule out between abrasion and abfraction according to PDL and bone changes? According to periodontal and bone changes, because they are quite similar in clinical aspects.
So we would be able to see, as far as periodontal ligament space, we can see widening of the periodontal ligament space. It can let us know that there might be some type of mobility to that. So that might be some clues for you. But I would say on average, we probably couldn't tell the difference between abrasion and abfraction.
Okay. And next question again from Dr. Suraj. Surgical implant stunts used with cone beam, is there provide 100% accurate guidance? I'll repeat.
Yes.
Surgical implant stunts used with cone beam, is they provide 100% accurate guidance?
Well, I have to admit, nothing is ever 100%. There's always going to be a plus or minus as far as being able to accurately place it. Different guides are tested to different levels or will promote different levels of accuracy. On average, we want to leave at least plus or minus 1 millimeter. And if we're trying to look at it in relationship to, say, the mandibular canal. In fact, sometimes when we do our measurements, we'll give an allowance of, say, even like 2 millimeters, because we don't want to get too close to it. So when we're personally measuring, we're going to measure it short. So we're not going to measure it all the way down to that canal. When we're looking at the accuracy of our surgical stents, they are very accurate, but we're still going to be careful as far as where we place it. I'm never going to trust everything 100%, but their level of accuracy can be down, as far as the research shows, plus or minus 0.04 or 0.03 millimeters. And so that's actually things that we found in research we've done ourselves, that they're very, very accurate, but it's not going to ever be 100%. Nothing is ever 100%. So we're always careful with that.
Definitely, ma'am. Next, we have from Dr. Gautam. Is there any CBCT machine in which FOV can be increased or decreased from 5x5 to 8x8?
Oh, yes. Yeah, there's lots of machines that are out there that are variable fields of view. I think most of the companies are really going more towards variable field of view units. And that's definitely something that I like. I like to be able to choose the not only the field of view, but the resolutions that I'm going to use. Now, they'll have pre-settings so that the dose is preset, which is great, because that can be designed ahead of time to decrease the dose for the patient.
But yes, we have variable fields of view units.
Okay. Next we have from Dr. Aniket. Can we able to see crack in tooth by using CBCT?
That's a great question. Can we see a crack in the tooth? And as I mentioned, if it's a root canal treated tooth, it can have a lot of artifacts with that, with the metal restoration, with the endodontic filling, and that can make it difficult for us to actually see the fracture line. We will look for it, but really what we're looking at is the evidence of that fracture. And so if I think I see a fracture line, but there's no associated bone loss with that, most likely what I'm looking at is a artifact called beam hardening artifacts that we see with cone beam CT. So we may not see the actual fracture line. Now, sometimes we do. The fracture has to be larger than the resolution of that particular volume.
Okay. Next we have, can we detect cyaloliths in CBCT?
Yes, very easy to diagnose these soft tissue calcifications based on their location and their appearance with cone beam CT. So we can easily distinguish between, say, cyalolith versus a calcified lymph node.
Okay. So we are not having much more questions to answer. And I hope all the questions of the participants are being answered. Thank you, ma'am. Thank you for the wonderful session you took and the knowledge you shared.
Wonderful. Thank you so much. I appreciate your time. Thank you for the opportunity to be able to share.
Thank you, ma'am. So with this, we'll move on to the end of the session. And thank you for the participants. And you can log into www.gomha.org for the certification and membership purposes. So thank you, ma'am. Thank you for your time. We'll move on to the end of the session.